Hi, I'm Jay Schuberg, a board-certified family physician and a fellowship-trained diabetologist at Touro University, California.
My name is Mark Melilon. I am an interventional cardiologist at North Bay Healthcare in Fairfield, California.
Today's topic is one that I think we've all thought about and actually quite often quote, is diabetes a cardiovascular risk equivalent? And Mark, I've worked with you. I love the work that we do together. I think we really, to start this conversation, we need to know, what does that mean? Is diabetes a cardiovascular risk equivalent? What's your take on that?
Perfect, Jay. Thank you for having me. So diabetes, as we all know, is a progressive metabolic disease characterized by insulin resistance and eventual functional failure of pancreatic beta cells. It is the impaired glucose metabolism that is linked to high rates of atherosclerotic cardiovascular disease, or ASCVD, morbidity, and mortality. Now, this is what led to the historical and somewhat incorrect classification of diabetes being a coronary heart disease risk equivalent, which implies a 10-year ASCVD risk of greater than 20% for every patient with diabetes. More contemporary data have shown otherwise.
Okay, so that's important. So we have a number that we could actually hang our hat on to say, this is the risk equivalent that we're talking about. And of course, I think you really highlighted that diabetes is an inflammatory vascular problem, but we see people across the spectrum of diabetes, and maybe that's an important factor. And I wanted to highlight that you had talked about the pathophysiology of type 2. And I think that's the other thing that we often focus on, is that the great majority of people with diabetes have type 2 diabetes, but that doesn't mean everyone does. And so when we talk about this, our initial thoughts are type 2, and then we can talk about other types of diabetes shortly. So how should I approach my patient with type 2 diabetes who doesn't have known cardiovascular disease?
Such a conundrum, such a question here. There is such a heterogeneity in risk among type 2 and type 1 diabetic patients. And this really poses a unique challenge to accurately risk stratify, as well as the selection of appropriate preventive therapies.
Yeah, and I think, as we think about it, I know that I don't want people to leave today thinking that there is no cardiovascular risk. We know that, a third of people with type 2 diabetes have a complication on the day they're diagnosed. And we know that 25% of people who present with acute MI find out that they have diabetes at that time. So I do think that there is an importance here, and that we need to risk stratify our patients. How should I risk stratify them? What's the best calculator? These calculators all are a little bit different.
I think all encompassing, it all starts with the pooled cohort equation, which factors in diabetes as one of the many risk factors for the development of either subclinical or clinical atherosclerotic cardiovascular disease. That's a wonderful tool. It is utilized for patients ages 40 to 75 years old. And for me, it's a great starting tool.
Yeah, and I think you've highlighted some really important things. So the great majority of our patients with type 2 diabetes will be between the age of 40 and 70. But we are seeing so many people now diagnosed at a younger age with type 2 diabetes. And at least what we've learned in the diabetes space is that the younger you're diagnosed with type 2, the more progressive this disease is, and the earlier you will succumb to complications if not aggressively treated. So I think one of the weaknesses of the current setting is that, what do I do with my 32-year-old that's had type 2 diabetes for 10 years? I can't use that same equation. So that's a challenge. Any suggestions?
In my patient population, I have been utilizing more coronary artery calcium scans, or CAC scans. They really help me with a very narrow sliver, or help me with risk stratification among this, again, very heterogeneous group of people here. It has emerged as, quote, the most sensitive and non-invasive risk stratification tool in this population. We know that a score of 0, or should I say a score greater than 0, is associated with a higher risk of coronary heart disease and events. And we know that the absence of coronary artery calcium portends a very low absolute event rate. And notice how I did say very low. I did not say zero, because that does not mean no statin, no other therapies, aspirin and the like, if you will. But it does help guide you in a narrow sliver of population of patients.
That's great. And I think, again, we need more tools to be able to really identify, because this diabetes is a relatively silent disease, as is heart disease. So one of the challenges that I have is look at the type of diabetes as it relates to cardiovascular risk. And I might be at fault here, but I really assume the great majority of my patients with type 2 are at very high risk because of that early complication. I struggle a little bit more with our type 1s in terms of how do we identify their risk, because it really is a different disease, right? I mean, we don't have insulin resistance. We don't have the same inflammatory markers. We do have hyperglycemia, but a lot of the risk calculators don't take that into account. When you see someone with type 1 diabetes, how do you handle that?
At this point in time, Jay, I can't say I handle it any differently right now. I don't have any hard endpoints of results or trials to guide me there.
Hmm. Yeah, and so that's a place of area where we should be doing some new research. I did find that for those with type 1, there is a much higher risk of mortality, and that mortality is largely driven by cardiovascular and renal complications. So in many respects, just like type 2. But what I was surprised to see was the duration of diabetes was not one of the biggest predictors. Age and hyperglycemia were bigger predictors. And so I guess as I look at my patients with type 1, I might need to risk stratify more actively by how old are they, and how well are they controlled. Um, so when I look at that, and let's say you have a person with type 1 I'm worried about, do I do all the same preventative treatments I would do for type 2?
I think at this point, I think that's probably the right thing to do. The latest guidelines that do guide would be the 2018 AHA-ACC multi-society cholesterol guideline recommendations. And in this here, they do state that moderate intensity statin is indicated for those diabetic patients ages 40 to 75, irrespective of the risk score or the pulled cord equation. That does not answer the question of less than 40, though.
Sure. Sure. So at this point, we're back to practicing medicine and doing the best we can with seeing the patient in front of us and trying to estimate their risk. The other thing that I think is important to talk about is what's the clinical presentation of people with diabetes when they have an unstable coronary event? I remember being taught that you're more likely to have a silent event, but I think it's important for us not to lose the communication tools with our patients. What do you share with your patients when they have diabetes, how they might experience an acute coronary event?
As you were alluding to, Jay, I shared with them the spectrum of symptoms, rather be it from the typical symptoms of angina, which would be a chest discomfort. It could be outside of the chest as well, in the jaw, upper back, or shoulders, to fatigue and shortness of breath, and those very nondescript, non-specific symptoms are also something I share with. And I usually tell people, I say, if it doesn't feel right to you, it doesn't feel right to me, and go seek medical attention.
I love that. I think that's important too, is that, people know when they feel different. And if they feel different, they should trust that and be cautious, especially when you have multiple chronic diseases.
Absolutely.
Yeah. So let's talk a little bit about kind of the nuts and bolts. So I have a patient who is, let's call her 48. She's got type 1 diabetes. It's been a long time, but duration maybe doesn't matter, but she's not been well controlled. And let's just say that she reports exertional fatigue. So of course I'm going to send her to my local cardiologist. I want to make sure she gets an evaluation. What are the steps? What are the first couple of things you're going to do? And then maybe treatment wise, what are some of the things we should be thinking about for that person?
So I think
Let's say,
after going through the stability or lack thereof of her diabetes control, I then would look at her blood pressure, her weight, her activity level. I'd get a glance at her lipid profile, and ideally that lipid profile would also have others It would have a lipoprotein A, which helps me refine my estimate. It could also have an apolipoprotein B as well as possibly a high sensitivity CRP or C-reactive protein. All of these numbers plus the symptoms help me risk stratify her in a more specific way. We're not at the time frame where we can attribute genome testing at this time, but that's where I'd start with those labs. And then depending upon the severity or lack thereof of them, I'd ask the question, is this somebody whose symptoms I trust are due to angina or not due to angina? And I'd ask myself if a functional or chemical stress test were appropriate. And if not so, then I'd also ask myself and the patient if a coronary artery calcium scan would be appropriate as well. But I think it all depends upon that patient presentation. And then, of course, at the very end of it and middle of it is the shared decision-making that is so important in this day and age.
And so I love that, right? I mean, it really, of course, you've taken this down a couple pathways. If that patient had type 2, and let's say that the workup was negative, the best we can tell with the information we got today, are there any special treatments that you would suggest as a cardiologist for the management of diabetes and cardiovascular disease?
So I think if the symptoms were very vague and to me not angina, but if I was concerned enough given the history of diabetes, and we'll throw in that blood pressure is uncontrolled and maybe a family history of heart disease, then I think if the calcium, coronary artery calcium score were not 0, I think I'd absolutely entertain the shared decision-making of a baby aspirin, as well as moderate to high intensity statin therapy for primary prevention.
I love that. And of course, now we have agents that treat diabetes that also help with heart disease. So at least dulaglutide has some primary prevention. And of course, if she had a positive test or she actually had an NMI, we have a plethora of SGLT2s and GLP-1s that we could be using that could really help with that.
Absolutely.
Yeah, so I think there's some important things to take from today. I think you said that, first of all, the old dictum that diabetes is a cardiovascular risk equivalent is probably too generalized and not exactly true, right? We actually have a wider spectrum of people with diabetes, and we really need to take a little bit more of a nitty-gritty approach, but use a pooled calculator, one that we can really kind of hang our hat on to estimate risk. So far, so good?
Perfectly said, Jay.
Okay. You've pulled in that we should be looking at additional factors, and I would really highlight, particularly for type 1 diabetes, look at other lipoproteins, look at the, kind of measures of inflammation, because certainly the traditional diabetic dyslipidemia may not be present as we currently measure it in type 1. And of course, we have new tools, or relatively new tools, they're not that new, like a coronary calcium score, that could really be quite helpful. And I think ultimately, at least in my primary care space, getting our patients who I'm worried about to the cardiologist is really important, because I think anyone that's listening in knows when they hear a story that they're uncomfortable. I'm not sure what this is. And if you're worried about it, this is the time to call in and get some help.
Perfect.
Anything you would add to that?
Not at all, except that in this day and age here, it is not just the diabetologist and the family practitioner that's instituting at least these new class of medications as well. It is a cardiologist, and the group that should take the reins here. Just less than 5% of all active cardiologists feel comfortable prescribing medications for diabetes, and I think that number will change as we go forward here.
Yeah, great point. Absolutely. Diabetes is a complex condition, and it requires multiple touch points, and every one of our team members should be empowered to intervene to prevent complications. And that includes using therapies that have been shown to reduce cardiovascular risk. I love that. So thank you for joining us today. And thanks you all for joining our topic.
Thank you.